Everyone. First of all, I would like to welcome everyone and who's attending this series of the webinar, which is being conducted under the leadership of the Mosquito Society along with the Sanofi. So today is the last part of this webinar series, that is the fourth part. And this session would be taken up by very eminent allergists and immunologists in our country and from abroad. So as you all know, the topics which we had covered in the last three webinars that included the basic and the clinical aspects of the various allergic diseases. So today we have with us as Dr. P.K. Vedantan, and Dr. Nagendra Prasad Kumarla, and Dr. Krishna Mohan. They all are very well-known allergists, immunologists of our country and also in the US. And it is my honor and privilege to welcome them all in today's program. I really thank them since they have taken this time out of their busy schedule to be a part of this webinar series, which is one of the innovative series being carried on by the Indian Chess Society. Thank you all. And I really thank the participants who had been attending this webinar. And I hope that it is really helping them. We'll have the series of talks, and at the end, we can have a discussion. And you can all put your questions in the chat box, and we'll take all the questions one at a time at the end of the entire program. So with this, we start. So the first lecture will be taken up by Professor P.K. Vedantan on food allergy. Though Dr. Vedantan needs introduction and to all who is practicing allergy immunology in our country, but still, for the sake of brevity, I would like to, and it's my honor to introduce him. Dr. P.K. Vedantan is a native of Mysuru, India, and a graduate of Mysore Medical College. He is certified by the American Board of Pediatrics, Allergy, Asthma, and Immunology. He is the founder chairman of International Asthma Services, a charitable organization since 1992. IAAs that Dr. Vedantan had been able to channel several of his activities, and since we all lovingly call him PK, so as PK has been doing this since 1992. Charitable academic research and transfer technology to developing countries with India has been the hub of this program. He has established and serves as the co-director for allergy as well immunology training programs at Christian Medical College, Vellore, Sir Gangaram Hospital, Delhi, and Kolkata, West Bengal, and also in Bangalore. In addition to conducting scores of the continuing medical educations and hundreds of allergy asthma awareness camps across India and 5 other developing countries, he has initiated the Prana charitable allergy asthma clinics across India, Nepal, and Barbados in West Indies. He is the founder chairman of the Allergy Asthma Network of India with membership of more than 400 qualified allergy specialists across India and beyond. He is a lead editor of the textbook of allergy for the clinician published by the CRC Press. He is a recipient of several awards, the major ones being the Excellence in Global Health in 2015 awarded by the Center for Global Health, University of Colorado. A Faculty Innovator Award in 2018 by Department of Medicine at University of Colorado, Denver. Service Above Self Award by Rotary Club of Fort Collins in 2002. And recently, the Special Recognition Award for 2021 by the American Academy of Allergy, Asthma, and Immunology as a Portrait. PK is married to Mrs. Kamala and has 2 grown-up children and 2 grandchildren. I welcome you all, Dr. Vedantan. I welcome Dr. Vedantan, and it's a very warm welcome from the entire team of this webinar. And he would be talking on his first talk is on the food allergy, and we'll again hear from him, and we'll have another talk on the basics of the allergen immunity. So it's over to you, Dr. Vedantan, and with this. Thank you.
Thank you very much, Dr. Saibal. That was actually a very long introduction. I wanted something in 3 lines. It's all right. But thank you again for all the efforts that you are putting to have this educational outreach in partnership with Sanofi as well as the India Chess Society. It is commendable that you are able to do this on a regular basis, and I am very happy to be involved in this endeavor. And the topics that you have allotted me are actually both are hot topics. Food allergy is hotter than allergen immunotherapy now. So I'm going to talk about food allergy first. Since I thought this audience will be mostly chest physicians, initial part of the talk I wanted to just include some basics on allergy and then go into specifics of food allergy. So what I will do is I'll go first few slides fairly fast and then I will go more into food allergy. So can I go ahead and share the screen now? Yeah, let's see. I hope.
Yes.
Hold on a second. This is immunotherapy. So let us see if this is the one. Yeah, so this is it. Can you see it? Okay.
Yes, we can see it.
Okay, great. Thank you. So, food allergy.
It's not in the projection mode.
It's not in the
It is. I put it.
It is in the file, but it should be screen mode.
I did. It is full screen.
No.
For me,
I think it may take some time.
Oh.
And so this is the allergy and immunotherapy talks lectures. No?
How is it now?
Yeah, this file belongs to the allergy and immunotherapy.
Therapy.
No, this says food allergy for me, no? Okay.
No. This is allergy and immunotherapy, nuts and bolts.
This is allergy and immunotherapy.
Sir, stop sharing and try again, sir. That will be better.
Yeah.
Let me shut off the share and come back again.
Yes, sir.
Yeah.
Because there's two of them, they are sort of overlapping each other. Okay. Let's start from the beginning. Now, this is again food and
Same file.
Yeah, you're right. Let's go to this one. Right?
It's again the same.
You are clicking the same file.
Both look the same, that's why. Can I go back and get that one from my this thing and come back? Is that okay with you?
Yeah. Yes, it's
Because, hold on a second. Sorry. Okay. Yeah, I think I'll have to go back and come back, okay?
okay, sir.
I'll have to go back and come back. Takes me 2 minutes.
Other way around is Bansal Priya has got set up yours.
No,
She can do it now.
Or
I should be okay. I'm coming back.
Okay, fine.
okay.
Sorry about that, but it should be okay. Allergy immunotherapy. Bansal has it? Food allergy?
Yes, sir, I can share it just a second.
How is it? I am not able to bring it. Because I made a few changes. Let me eliminate this. What is this one? Allergy immunotherapy.
Sir, I hope this is visible. I can move to the next slides when you tell me to.
Yes, it is visible right now.
Can you see it now?
Yeah, we can see it. Yes.
Is it food allergy now?
It's food allergy now.
Are you okay? Okay. Let's move on. Sorry about that.
No, sir.
Okay. So we start off with the basics and then go into specifics. So basics, I don't want to spend a whole lot of time here basically telling that this is a type 1 hypersensitivity reaction where there are two phases. One is sensitization, another is re-exposure. And you are very familiar with this slide and the principle behind this. In sensitization, the antigen is taken up by the antigen presenting cell. With this T cell, B cell interaction, you have the specific IgE production, mast cell activation on re-exposure, and release of these mediators and the allergic reaction. Now, coming to this food allergy, it is a very loosely used term. So, in order to encompass these terms, we use a word called adverse food reaction, where it's a generic term, it's an umbrella term, which covers up all these different types of terminology that we use. Adverse food reaction can include food allergy, food intolerance, toxic reactions, non-immunological reactions, immunological reactions like that. So it is sort of an umbrella term. But when we talk about food allergy, we mean it whether it should be an immunological reaction. It could be IgE or non-IgE mediated, but it has to be an immunological reaction. Whereas there are certain non-immunological reactions that can happen due to foods, due to different reasons also. Now, if you look at the prevalence, it's much more common in younger children, especially the younger the child. The prevalence seems to be more, 68% in the United States. Almost like one child in every 13 children are allergic in USA. And as you get older, the prevalence seems to get less. But I have seen some data recently where the prevalence seems to be quite high among adults too, especially for seafoods, where the prevalence seems to be much higher when they are 50, 60-year-old. So that is something newer that we are seeing now in the adults. Also, the prevalence seems to be quite high. Now, let us see, if you ask someone, does foods bother you? 60, 50, 25 to 60%. I would say at least 50% of people say yes. I am allergic to this food, I am allergic to that food, this bothers me, it gets me bloating, it gives me abdominal pain, I feel discomfort, I feel tired. But they use the term allergy for all these different type of symptoms. So if you look at in a strict fashion, what is the prevalence of food allergy? It's very low. It could be as low as 1% or maybe less, or as high as 8 to 10% in some of the westernized countries. But it is never 50%. So 50% is the perception, what people have. So what it means is people come to you thinking they are allergic to different foods. It is our duty to figure out, are they really truly allergic? If they are not truly allergic, then we should educate them, because they may be eliminating those foods unnecessarily. And there are many practitioners as well as many laboratory outlets that confuses them more, because there are so many questionable tests that are available that makes them more confused. So we need to be very much aware of this situation And you should know that food allergy is one of the most confusing items on not only in people's mind but also among health professionals. Now, what prevents you from getting food allergy? How is it most of us are not allergic? We eat so many different types of foods every day. Every day you have variety of foods, especially the Indian food has so much variety, but we are still comfortable. How is that? Because we have what we call as a built-in tolerance. We have a built-in tolerance. Our gastrointestinal tract is tolerogenic. We have a very, very good working epithelium, which has got a tight epithelium, very little leakage there. And there are what we call as a thing called glycocalyx, which traps the food particles. We have these tight junctions, which doesn't allow the food particles to get into your system. Plus, in addition to that, we also have certain immunoglobulins like IgA that seems to also protect you against food allergies. And in addition to that, we have what we call as a oral tolerance. What is oral tolerance? Oral tolerance is a state of immune unresponsiveness to food antigen. That is a very interesting phenomenon, and this is something very important for you to know, because this is a normal phenomenon. How is it your immune system is unresponsive? Because as I just explained to you in the first slide how the allergic reaction works, the antigen presenting cell picks it up, present it to the T cell, then the B cell will react, B cell will respond. This is a professional way of doing things. But in the GI tract, the antigen presenting cell is non-professional. It doesn't know how to present to the T cell properly. And the T cell itself is tolerogenic. It doesn't respond like it's supposed to do in the other immunogenic organs like skin. And the food antigen by itself is a poor antigen. It is not a powerful antigen, especially in the gut. So with all this combination, we have what we call as an immune unresponsiveness or hyporesponsiveness, which actually is potentiated by exclusive breastfeeding. Breastfeeding promotes hyporesponsiveness, which helps. That is why children who are fed with breast milk for prolonged periods develop less food allergies, because there is maturation of the gastrointestinal tract over a period of time. They also develop oral tolerance. So this is oral tolerance is a very important feature that you need to know. And this oral tolerance can be disturbed by several things like antibiotics, antacids, and all these different things can do. And that is why the microbiota of the GI tract plays a major role here. And you need to be aware why it is important for us to maintain that diverse flora in the GI tract. Diversity of the flora in the GI tract is what makes us hyporesponsive, and that what makes us tolerate these foods and keeps us very comfortable. So it is an effective barrier. You have the oral tolerance, and the breastfeeding promotes it. But why do other people get food allergy? Because they have a leaky gut. It is a genetic problem. If you take allergy per se, we say it is a gene-environment interaction. What is a genetic defect in allergy? It is compromised epithelial integrity. That is, the epithelium is not tight. It's leaky. So you have a leaky epithelium in your skin, respiratory tract, GI tract, and that is the genetic defect. The tight junctions are weak. The cement between the cells are weak. So it lets the food in, lets the antigens in, and it's a leaky gut. And also because of the lower content maybe of the IgA, and also because of the genetic predisposition to have Th2 type of environment. So this leads to more food allergy. So it is the leaky gut that causes the problem. So it is an epithelial disease that causes that. What happened? Now, if you look at the type of foods that cause this problem, it doesn't move very well.
Now it is moved.
Okay. Now, food antigen is a heat stable antigen. That is why even if you cook the food, it can bother you. So, and the molecular weight is fairly small. What are the most common allergens in children? You need to be aware that you don't have to test for 45 different foods. 10 foods will cause 80% of the problems. So if you look at this common allergens in milk, is depending on the Western diet, it's only milk, eggs, peanuts, soy, and wheat. Now, one point of caution that you need to know, say like you have a child with eczema, and you do, and the mother says, this child is, when I give eggs, it bothers the child. Then you do a skin test for eggs, it's positive, or you do immunocap, it's positive. But you also have to know these children can have coexisting sensitization, especially with peanuts and milk. So milk, peanuts, eggs, they go together. So whenever you see a eczema patient whose history may suggest sensitivity to either egg or milk, just don't stop there. You have to look for this is what we call as an accompanying allergens. That's very common. These three things go together, especially in patients where you want to introduce. Nowadays we are talking about introducing allergenic foods, and if the mother says he's allergic to eggs, and don't assume that you can introduce milk and peanut in that patient because only the egg is the only offending agent. You have to look for it both by skin testing as well as immunocap if necessary, and it is not uncommon to demonstrate that these three antigens seems to go together. Milk, eggs, peanuts seem to go together. In adults, the type of antigen is a little bit different. It is shellfish has a lot more sensitization allergies there, peanuts and tree nuts. And nowadays, we are also having some newer allergens that are coming up in more prevalence. I already told you. Now, because of this history of few foods causing the problem, what you need to do is you need to get, before you go and make any diagnosis or do any type of testing, I can't go back, that's the problem. Some problem.
Priya, can you help with the Vedanta?
Yeah, I got it now. Now, first few things here. Please be aware of this. Please test for only few antigens. 10 food items can cause 90% of the reactions. And these are these foods. Do not test for unnecessary foods because you are going to get confused. Patient will get confused, and it is not necessary. Now, if you ask me, where will I get the antigen, sir? Say, for example, my colleague Dr. Vinay Mehta does not use any commercial foods, because commercial food antigens, over a period of time, they undergo certain changes. What you eat and what you test are different. So he will straight away do prick-on-prick test. He will take the milk and put it right on the skin and just do the testing. So that he finds a lot more meaningful and clinically relevant. It is not standardized, looks a little crude, but as far as clinical relevance goes, it has much more value than commercial food antigens. Always listen to the patient and family before selecting antigens for testing. So history is very, very crucial. Now let us come to the current issue. Why this changing platform? Now we are realizing that food allergy is changing. It's very fast. In the past 2 decades, especially in the past decade, at least every journal has at least 1 or 2 articles, really good ones, on food allergy. Incidence is increasing, prevalence is increasing, awareness is increasing, diagnostic methods are increasing. We are also definitely getting better tests with this component diagnosis and all that. But do we completely understand what's happening? I still do not know. Completely answer is still no. We cannot figure out what exactly is happening here because it is in a flux. And some of the changes happening are almost 180 degrees different from what we used to say about 10-15 years ago. And I will show you a slide on that. So with all the changes happening, you need to be aware of it. Now, this term is a very useful term, and this is something you need to understand. It's called dual allergen exposure hypothesis. It's not hypothesis anymore. When it came on in 2008 by Dr. Lack, in this article, they talk about this. The summary of this whole article was the sensitization of the foods does not occur through the gut. It is occurring through the skin. Actually, the tolerance is occurring through the gut. So now we are having these children who are getting sensitized through the skin because the skin is extremely immunogenic and food antigens get through these compromised epithelium I talked about, provokes the IgE production, and patients get sensitized. And when you are eating the same food through the gut, you are getting tolerogenic. You are getting tolerant. So that is the principle behind introducing early peanut ingestion in these children. So go ahead and give these allergenic foods by mouth, not through skin, by mouth, so that you will develop tolerance. So important point is introduce allergenic foods early enough through the mouth orally to promote tolerance. That was the principle, but it has got its own risks also. Now, there was a period where when we were going in this flux, during this period, in the early 2000s, we felt, they were doing immunocaps a lot and found these children were highly sensitized to these foods. But we did not know these children were not getting sensitized to the skin, and they were also eating those foods, and they were also, because of they were eating the foods, it was tolerogenic and they were able to handle it. There have been many instances based upon the immunocap results. They eliminated these foods, and that resulted in huge allergic reactions, including anaphylaxis. It's called paradoxical anaphylaxis due to removal of the food. So we are very familiar by having anaphylaxis by introducing a food. But this occurred because of removal of the food. Reason is the protection that was induced by oral ingestion of the same food was removed in these patients when you stopped eating that food, and the sensitization continued to occur through the skin, and that provoked the reaction. So that was the reason behind it. So when you do immunocap and you show this positive, don't be in a hurry to remove it, especially if the patient is doing well. The other implication is, if the patient is doing well, do not do any type of food screening. Patient says, I'm fine, I'm eating peanut, I'm eating eggs, I'm eating milk, child is fine, doing well. And the mother says, my other child has food allergies, can you please check my child? Can you please do an immunocap? Somebody told me it's a very good test. Answer is no, I don't want to do it, because I will probably cause more problems for you by doing more tests, because I don't know what to say. So never do screening by immunocap unnecessarily unless you have a history of certain foods bothering you. So atopic individuals may be in a state of natural desensitization that can be lost with allergen avoidance. That is the message of this study. So you could cause problems by unnecessarily doing tests and taking off the food, and you actually may promote an acute allergic reaction. I hope you are able to follow. Now, there is a thing called second wave of allergic disease. The first wave was in the 60s. Now we have this potential allergic tsunami where you have all these different people who are doing fairly well, suddenly getting all these allergies, which is called allergic tsunami in developing countries. And it is already set in developed countries, where in USA there has been a 300% increase in peanut sensitivity allergy, Australia 500% increase in anaphylaxis. And one of the best studies done was called Health Nut study in Australia based upon oral challenge. The sensitization was 18% and the challenge positive was 10%. 1 in every 10 children is definitely physician proved allergic. It is not just history, it is proven allergic based upon the oral challenge. So that is a huge increase. And is one of the reasons is also acculturation. That is people, Asians living in Australia and being grown up because of the culture, the environmental changes, cultural changes, but genetically the same. It causes a sort of a very susceptible combination to develop allergies. So one of the changing scenario. So say like I was in practice about 25 years ago, what was I telling my patient? I used to say, avoid allergenic items, don't take milk, don't take eggs, don't take peanut, introduce it at 2 years, introduce it 1 year, like that. Avoid cats, avoid dogs, avoid infections, avoid peanuts, and all those things I was saying. And I would say, food allergy, I can't treat you. It is untreatable. Just elimination is the only way. There is no way immunotherapy. But now, we are telling 180 degrees different, completely different. We are saying introduce allergenic foods early, have dogs in the house, because it is one of those microbial exposures that promotes Th1. Daycare is good. Have this child exposed to more infections so that you will have much more immune maturation. Introduce peanuts early, depending on based upon that LEAP study, or many other allergenic foods like milk, eggs too. But you have to know that LEAP study also has certain limitations. You need to screen them before you can introduce these food items. Do not introduce blindly. So, but in case the child is able to handle it and not sensitized, and then you go ahead and introduce, definitely it will help to produce oral tolerance. And food allergy now is treatable. And now we are able to also offer oral immunotherapy for the first time for accidental exposures. So we have come quite a long way, and this will continue like that. So this process will continue, this cycle will continue. This is just a basic summary. Early exposure at 4 to 6 months promotes oral tolerance, seems to be protective. Prolonged avoidance, if you go ahead and avoid this food, oral tolerance is missed out and you get more sensitization, more allergy. And lifestyle is very, very important, and that has got a huge role in food allergy, especially with affluence. People have a lot of money and they eat all sorts of things, and they have all these foods that are sort of not like, for example, peanuts. We have eaten a lot of peanuts before as child, but we don't have peanut allergy. India and China are one of the major countries in the world having the maximum consumption of peanuts and the least allergy. Why is this? Because peanut is consumed in a different manner. Here, peanut is boiled, peanut is fried. What happens in USA? What happens in UK, Germany, where the peanut is heated up, it is dry roasted. When you dry roast the peanuts, the amino acid configuration changes, it becomes a lot more antigenic, and it is highly allergenic, dry roasted peanuts. And there is also a difference between genetics, acculturation, race, ethnicity. All these things play a role in food allergy. And risk factors like more women than children, especially older women, develop now food allergies, especially with brinjal and seafoods and all that. Asian and black people are more susceptible, and genetics definitely plays a role. Vitamin D insufficiency and less omega-3 fatty acids, increased use of antacids, which actually takes away that protection in the which the acid gives you to the stomach and makes the food a lot more susceptible for antigenicity. And that is another issue that you need to know. Obesity, timing, route of exposure, especially through the skin, all these things are all risk factors for developing food allergy. And one word of caution, sensitization does not mean allergy. That is, say like you, when Dr. Mahesh did this Europroval study, he found that sensitization for foods in the Indian children was almost 26%, very, very high. Whereas sensitization in US is only around 10, 14 to 12%. But the incidence of allergy there is 8 to 10%. So what was the true incidence of allergy in the Indian children whose sensitization was 26%? They did not do oral challenge. Based upon the history, they found that the children, the allergy prevalence was only 0.01, which is extremely low, which means these are at two different ends. Sensitization and allergy don't go hand in hand. So when you do immunocap, which is not a good idea to do on a screening basis, you should be very, very careful when you interpret it. It does not mean allergy. It only means sensitization. It also could be false positive because the IgE could be directed against the carbohydrate component of these antigens, not the protein component. Vitamin D, it is very interesting that away from the equator, away from the sun, way up there in the North Pole or in the upper parts of Russia, Norwegian countries, Baltic countries are way down in the south. The treatment for epinephrine, the frequency of anaphylaxis is extremely high. So sun has something to do. The way you live has something to do. So probably we have a lot more allergic emergencies in the temporal climates than in a tropical country like India. Probably the sun has some role in it, and vitamin deficiency probably has a major role in it. And what can we tell our patients? So skin care is very important. Use less soaps, keep the ceramide thing, keep the skin healthy, less detergents, more moistures, early introduction of solids, complementary food, start around 4 to 5, 6 months of age. Make sure there are no other risk factors. Encourage breastfeeding irrespective of protection against food allergy. And also, we don't have a whole lot of reliable data on probiotics or prebiotics. I don't want to get into that. And peanut allergy, as you know, is very, very common. Asian countries have low prevalence. I already told you why. And it has got all these different proteins depending on this component testing. It tells us which one is the problem. But roasting of peanuts increases the antigenicity 90-fold. So do not use roasted peanuts, because nowadays children who have got all this disposable money with them go to these stores, modern stores, and these modern stores don't sell regular peanuts like we used to buy. They sell it in very, very attractive packets which have got these roasted peanuts, and the roasted peanut tastes very good, but it can cause huge amount of allergies. Autoclaving reduces, and leap study is something you are very familiar with, where early introduction of peanuts to high risk group was shown to prevent, but there were certain associated risk factors which need to be which you need to know, that eczema as well as the prevalence of sensitization to eggs and peanuts have to be taken into account in these children. So don't just blindly introduce peanuts in these children. First look for risk factors and then introduce. And there is lastly one thing, is there is an item called alpha gal allergy. It is due to a lone star tick mite. It is a tick which is present in the US, in the southern part of USA. It's also now, it's not found in India, but we are finding sensitization to it in different parts of India. So I think it will come here also. The important here is due to the tick bite, the antigen that is introduced is related to tropomycin, and also it cross-react with an antigen in the red meat. And this is one of those factors which causes what we call as delayed anaphylaxis. They take the red meat, 5 hours later they get an acute allergic anaphylactic type of reaction. So you need to be aware that food allergy is changing, the route of sensitization is changing, and the manifestations are changing, and you need to be aware of all these different items in food allergy. So let me stop here. And I want you to be aware of this changing platform, and thank you very much.
Thank you, Dr. Vedantan. I think this is a very interesting topic, and we are seeing that there's lots of changes which is coming up in the concept of how we look into the food allergy in recent times. I think we'll take the questions at the end.
Okay.
And now we move on to the next topic. The next topic is it is on the drug allergy, and this would be taken up by another very illustrious as allergist immunologist of our country, Dr. Nagendra Prasad Kumar. So let me introduce Dr. Nagendra Prasad. So. Dr. Nagendra Prasad Kumar, he's an allergy physician at Bangalore Allergy Center since 1980. And he has published 29 original papers presented in national and international conventions, journals, and many chapters in books. He's a member of YACI, WAO, ERS, and Quaterei. He's a fellow of the Indian College of Allergy and Immunology since 1984. He's a life member of 17 medical societies in India, trustee of the Bangalore Allergy Foundation and the Bangalore Allergy Foundation BAF Academy. Slit drops was introduced for the first time in India in 2003 by his foundation, and slit tablets and strips in the year 2014 got approval for personalized dispense license from Karnataka Drug Controller. Is the patent possession of the invention non-woven nasal filters, filter masks, slit strips. E-flow indicator is a joint possession in collaboration of Indian Institute of Science, Bangalore, and is a patent pending on a slit Hyostas tablets in 2015. So we see that Dr. Kumarla is a renowned allergy physician in our country, and he has actually paved the way in our country towards the sublingual immunotherapy, which we all know is still we have lots of utilities and its advantages as in the patients who we treat. So thank you, Dr. Nagendra Prasad, and I would like you to take over this stage and just deliver this talk on the drug allergy.
Good evening to all, and thank you, Dr. Saibal, for your nice introduction. Today I'll be discussing about drug allergy, how to identify and manage. It's a very, very important field. One has to know because we are using a number of pharmacological chemicals, and which is now recently we are introducing the biologicals, which is also very important, which is having the adverse events. I have some problem. It is hanging. Yeah. Today we'll be discussing about the drug allergy with a case presentation as a single case, and definition and classification of drug allergies, and clinical features, assessment of hyperreactions to drugs, and diagnosis by in vitro and in vivo, and management. This is one of the PubMed when we logged into the drug allergy, which has shown that from 1945 to 2022, the number of papers published, still it is going on. That means the incidence of drug allergy is increasing as the number of drugs are in practice. We have one 9-year-old girl who visited the emergency department due to sudden onset of sneezing, nasal itching, urticaria, angioedema after paracetamol injection. The history is very clear. And again, it is confirmed with a specific IgE test, and which has shown that paracetamol is one of the culprit, which is showing the responsible for reactions. And it is confirmed with an intradermal test. And again, it is advised to avoid the paracetamol and associated drugs. The adverse drug reaction is defined as any harmful or unintended reaction to a drug that occurs at doses used for prevention, diagnosis, and treatment. This is a small contemporary model for drug hypersensitivity, which is when we pass through the prism, we have 3 divisions called phenotype, endotype, and biomarkers. Phenotype, we had to know what is the type of drug, what time the drug was given, and what are the symptoms developed and severity. Endotype like mast cell mediated, cytokine released, then the mixed site. Biomarkers, in vivo and in vitro test. So the classification of phenotype-endotype relationship in immediate hypersensitivity reactions are the endotype like mast cell basophil mediator deregulation, and which is a phenotype which is responsible for nasoocular symptoms, cardiovascular symptoms, and so on. And similarly with the cytokine release related, which is also having a phenotype of a constitutional symptoms like fever, chills, rigors, and headache, and having followed by cardiovascular components. So similarly with the mixed one. So what are the common drugs which is inducing the allergies in our practice? One is penicillin and other beta-lactams, which is already well known over a couple of years. Then we have the non-beta-lactam antibiotics, reactions during general anesthesia due to neuromuscular blockers, anesthetic agents, latex, which is used during general anesthesia in the form of gloves, local anesthetics, aspirin and NSAIDs, EC inhibitors, plasma expanders, gelatin, and dextran. My slide is not moving.
Priya, can you just check the back end? So, some issues.
Yeah. Sir, if you want, I can share the slide.
I don't know. Yeah, I think that's the better.
Yeah, Priya, I think you still.
Just a second.
Put on.
Dr. Prasad, you can stop sharing and then I'll share my screen.
Yes.
Yes. Luckily, it's moving now. Yeah.
Okay.
Can you see the screens? Yeah. The other drugs like insulin, heparin, opioids, vaccines, radio contrast media, chlorhexidine, iodine. So drug hypersensitivity reactions are adverse effects of drugs that clinically resemble allergic reactions. And international consensus like ICON on drug allergy, they say it is hypersensitive reactions are non-allergic and allergic. Among the allergic is the Ig mediated and non-Ig mediated. And this Rawlins and Thompson proposed in 1977, again in 1981, as classified as type A and type B. Type A is almost 85 to 90% of ADRs, is because of the pharmacological adverse effects and drug interaction. Example, like diarrhea in response to the antibiotics, gastritis with NSAIDs, sleepiness caused by the first generation antihistamine, theophylline toxicity with erythromycin. And type B is non-immune mediated and immune mediated, which is quite different from pharmacological actions. This table, you're all very familiar, is a gel and classification. 1, 2, 3, 4.
I think, sorry, Priya, can you just share the slides?
Could you see?
Right.
It's not moving.
No, Dr. Prasad, it's stuck on that same slide. No worries,
Okay.
I'll share. If you can just unshare your
No,
screen.
you're
I'll
not
share.
able to see. You're not able to see now.
No, not yet.
Okay. I will stop sharing.
Okay.
Yes, madam.
Yeah, now.
Yeah.
Yes.
Next. Can you navigate? Yes. Next. Yeah, this is one of the table which is very familiar by all the people who are familiar with the allergies. This is Gell and Comb classification. We have type 1 to type 4. The drug allergy will come in all the types, which is the only one place where you can see all the reactions in all the types of modes, which has been explained by Gell and Combs. And we'll focus on a different mode. I'll be dealt in the future slides to come. Next. The clinical classification, which has to be dealt as immediate or a non-immediate, which is less than 1 hour or more than 1 hour. And if it's a less than 1 hour, it may be in terms of seconds to within few minutes and gradually decline over a period of 4 to 8 hours. And which is late phase, which is happening after 6 to 8 hours or more than 1 hour, and which is constantly persists for more than 24 hours. And there are some reactions which happens after 24 hours and runs in days, like 7 days to 8 days. Next. Again, we said that immediate and non-immediate, immediate reactions like urticaria, angioedema, respiratory symptoms like rhinitis, bronchospasm, or dyspnea, gastrointestinal symptoms, anaphylaxis, or anaphylactic shock. Non-immediate maculopapular exanthemas, delayed appearing urticaria, angioedema, and a scar, that is skin reaction. Shortly. Next. So the allergy reactions that happens in the skin, which is commonly seen like urticaria or angioedema, maculopapular exanthematous eruption, and Stevens-Johnson syndrome or TENS, and photoallergic reaction and a phototoxic reactions, that is non-IgE mediated, and allergic contact dermatitis, sensitized T lymphocytes. Next. So these are all signs and measurements you had to keep in mind. These are all alert signs whenever you happen with the therapy. It is a sudden onset of a multi-system symptoms. It is a reduced blood pressure, which is always known as anaphylactic shock, which is very familiar. And inspiratory dyspnea, dysphonia, or siluria, which is laryngeal edema, and a painful skin, atypical target lesions, that is erosion of mucosa. You will get a skin blisters, bulla, and Nikolsky sign, and blood count, and also renal function failure, SJS and 10. He was associated with a fever more than 38.5 degrees centigrade, skin exchange 50% is involved, and a central edema, and changes happens with the lymphadenopathy, and the blood count and the liver function changes, and proteinuria, which is again with the HSS, DRUS, and DHS. And purpuric infiltrated papules are a necrosis, that is blood count, renal function, hypocomplementation, and which is a vasculitis. Next. Clinical manifestation. You have to keep in mind about how these drugs are represented. Exanthemas is a common and usually develops days after the medicine. Typically described or morbilliform, that is maculopapular, like looks like vessels-like. Immunopathogenesis, T cell mediated. Next. This is a maculopapular exanthema with a widespread erupting macules and papules. Next. Vasculitis with palpable purpura. Next. Symmetrical drug-related intertriginous and a flexural exanthem with intertriginous distribution, that is between the axilla and a groin region and between the breast wall. Next. Urticaria with wheals persisting only for less than 24 hours at the same time. Next. A drug fever is very commonly seen in the practice in the inpatient, caused by release of the pyrogens from the phagocytes immune complex, or it is T cell mediated, typically 7 to 10 days after the therapy, and a fever pattern variable, relieved within 48 hours, stopping the drug. Next. There is an injection site reaction with an indurated violaceous plaque after subcutaneous injection of a drug. It could be anti-rabies vaccine or insulin, etc. Next. Coming out of the fixed drug eruption, mechanism is not known. Typically develops 1 to 2 weeks for initial reaction, but sooner with a later exposure. Occur in the same location with the subsequent exposure to the drug of a previous lesion, and pleomorphic like eczema, erythematous papules, hyperpigmented, fullness, urticaria. Commonly we see in tetracycline, NSAIDs, carbamazepine, and sulfur. Next. There is a bullous fixed drug eruption with a central bulla on the sharply demarcated violaceous system. You can see the erythema as well as the bullous eruption. Next. There is one more condition, serum sickness, which you all know. It is mediated by immune complexes, heterologous antisera, snake antivenom, rabbit antithymocyte, globulin, and rituximab. Clinical features: fever, lymphadenopathy, arthralgias, rashes, GA symptoms, proteinuria. Typically occurs after 1 to 3 weeks. Next. Small molecular weight agents like penicillin, sulfonamides, thiouracil, phenytoin may lack features of immune complexes, hypocomplementemia, vasculitis, renal disease. Cephaclor, most common cause in children, altered metabolism leading to toxic reactive intermediates. Next. So severe cutaneous adverse reactions, which is given in the different names, which is maybe confusing, but it is already seen in the literature, and which is called scar. There is one condition. Next. No, previous please. One condition called AGEP, that is acute generalized eczematous pustulosis. DRUS is a drug reaction with eosinophilic systemic symptoms. SJS and 10, that is Stevenson-Johnson's toxic epidermal necrosis. DIHS is drug-induced hypersensitivity syndrome. TBFDE, that is generalized bullous fixed drug eruption. Don't get confused with any of the names. Just I will be presenting with the clinical features so that you can appreciate well. Next. So, acute generalized eczematous pustulosis is characterized by fine pustules, fever, and neutropenia. Rash begins in intertrious areas of face, edema, and erythema. Non-follicular sterile pustules develop afterwards. Atypical target lesions, blisters, and mucosal involvement resemble SJS or 10. Local T cells scream, secrete high amounts of IL-8. Next. So DRUS is a drug rash eosinophilia, systemic symptoms. Positive drugs are anticonvulsants, sulfonamides, allopurinol, minocycline, dapsone, namiprine, hydrochloroquine, and vancomycin. Next. This is a generalized eczematous pustulosis with the superficial pustules on erythema. You can see. Next. So clinical features of the DRUS is a rash, that is exanthema erythroderma, erythema multiforme purpura. There is a facial edema in diffuse and may be mistaken for angioedema, then genital and extremity edema, or a fever seen in majority of the cases, hypotension 40% of cases. Next. The hematological abnormality is eosinophilia more than 50%, then followed anemia, neutropenia, thrombocytopenia, and less cytosis. Hypogammaglobulinemia in a few cases. Next. And lymphadenopathy is less than 30%. Liver involvement is more than 60%. Renal dysfunction less than 30%. Out of 30%, which is caused about 80%, 40 to 80% with allopurinol. Respiratory and cardiac less common. Eosinophilic pneumonitis, cough, dyspnea, pharyngitis, pericarditis, and myocarditis common. Next. Reaction occurs after 2 to 8 weeks of therapy. Symptoms may worsen after drug discontinuation. Symptoms may last weeks to months after drug discontinuation. Next. This is a drug reaction with eosinophilia and systemic symptoms with a widespread erythematous infiltrate lesions. Next. Now coming on to the severe reactions, late phase, that is Stevenson-Johnson syndrome, which is commonly known as SJS, and a toxic epidermal necrolysis, that is called TEN. It is representing a spectrum of a single reaction. SJS less than 10% of total body surface area, whereas 10 is more than 30% of surface area involvement. Overlap is 10 to 30% of body surface area. Next. You can see the picture with the mucosal erosions that is around the eyes as well as in the oral cavity, and atypical target lesions and macules with the confluent bulla and erosions. Next. I said about the Nikolsky sign. It is a positive when the top layer of the skin slips away from the lower layers of the skin when rubbed. You can see in the oral, in the lips as well as the limbs. Next. A clinical features is a triad. There is one is a mucous membrane erosion either in the lip, oral cavity, conjunctiva, nasal cavity, and vagina. Target lesions, these are the fixed. Epidermal necrosis with detachment. Multi-organ involvement, gastrointestinal, hepatic, renal. Mortality, if SJS less than 5%, 10 is 10 to 50% or higher. or a high-risk patient in HIV, SLE, and BM transplant. Next. Coming on to the NSAIDs common adverse effect profile, which may be a gastrointestinal toxicity, cardiovascular adverse effect, or nephrotoxicity. Next. So drug interaction with the NSAIDs and commonly used medications like antiplatelet like aspirin, clopidogrel, and angiotensin converting enzyme, and angiotensin receptor blockers, beta blockers, calcium antagonists, corticosteroids, digitalis, glycosides, and diuretics, and methotrexate. Next. In 1922, Vidal et al. Coined Aspirin Triad, that is ASA-sensitive asthma and nasal polyposis. Aspirin-induced asthma affects 10% of the adults with asthma. That is, on ingestion of the aspirin, within 3 hours, asthma, rhinorrhea, conjunctivitis, and a periorbital edema. NSAIDs prevalence in asthma and nasal polyposis is about 30 to 40%. In chronic urticaria, the prevalence of NSAIDs intolerance is 20 to 30%. Next. Mechanism possible, the 3 hypotheses have been proposed. One is cycloogenase inhibition, overproduction of leukotrienes, and chronic inflammation of the airways. Next. COX inhibition. That is, 5-lipoxygenase and a COX catalyze the production of leukotrienes and a prostaglandins. Prostaglandins E2 has several immunomodulatory effects, including inhibition of 5-lipoxygenase and a prevent release of mediators from mast cells. Next. The enzyme that produce prostaglandin are called cycloogenase, that is COX. There are 2 types of COX enzymes, COX1 and COX2. COX2 inhibitors are a subclass of NSAIDs. NSAIDs reduce the production of prostaglandins that promote inflammation, pain, and fever, protect the lining of the stomach and intestine from the damaging the effect of the acid, promote blood clotting by activating platelets, and also affect kidney function. Next. We do have seen the cross-reaction between COX1 and COX2 inhibitors, though we say that COX2 is much safer than the COX1, but such may be having some life-threatening, it should be seen with observations after giving the COX2. Next. Coming out of the biologicals, which nowadays we are commonly started using in India about the biologicals, which also have some effects, though it may be very rare, but one should be very clear. May be causing the anaphylaxis, serum sickness syndrome, and neurological damage, and malignancies, and a cytokine storm, and immune suppression. Next. There is one example, just I want to give you a Stevenson SJS with which is a tomilizumab treated of adult T-cell leukemia or a lymphoma, which is one of the best biologicals which is used. And this patient was treated, and on the end of the therapy, they started with a SJS syndrome, and they started with treatment. And once the symptoms come down, again the second dose was given. Again, it is prolonged with the SJS syndrome, and again the third was given. So it is continuously they have treated, and they have SJS from it. Next. Coming on to the insulin allergy is a minor local symptoms to severe generalized allergy reaction. IG-mediated symptoms occur immediately after insulin injection. Skin reactions vary from local erythema and swelling at the site of injection. Flare reactions can also be elicited at the injection site upon insulin injection. and a pleuritis of forms, lies flushing, and itching can occur. In rare severe cases, anaphylaxis with dyspnea and a hypotension also observed. Next. Now, in the recent times, the heparins are very commonly used, especially with the COVID management. So we have a type 4, type 2, type 1 reactions. So first exposure may be having a sensitization, which may have a days and weeks and months, which may be having the T lymphocytic, and on the re-exposure, there is the 1 to several days, that is plaques and exanthemas. And if IgG is a responsible elicitation, few hours, some days, that is a thrombopenia. And IgE and re-expose this elicitation with the minutes and several hours, that is the urticaria and angioedema, anaphylaxis, and bronchospasm. Next. So this is adverse events which happen: bullous hemorrhagic dermatitis, and also a thrombocytopenia type 2 reactions we can see in child. Next. Coming out of the pseudo-allergic reactions, which is a non-IgE mediated mast cell activation, common examples with the drugs like opiates, vancomycin, radioimmunocontrast media. NSAID is inducing urticaria. And innate immune reactions is a complement activation, bradykinin release. Next. So we have a cross-reactivity among drugs. So the clinical manifestation when a drug not previously administered elicit hypersensitivity reactions because of a pre-existing sensitization to a structurally related compound, or because of a common pharmacological characteristics given earlier. Next. So the presence of a common antigenic determinant in the cross-reacting drugs, like in the penicillin, you can see the ring which is having a common platform in the cephalosporins, then sapaminics and oxazepamines and phenols, etc. Similarly, with the sulfonamides, basic structure having similar structure with a sulfamethoxazole. Next. So 38% of the subjects with a selective response to the amoxicillin developed a cross-reactive with a ceftriaxone, which shares an identical side chain at the R1 position with amoxicillin. Similarly, 12% of the subjects with a well-demonstrated IgE-mediated hyperreactivity to penicillins and developed a cross-reactive with the cephalosporins with a similar side chain. Next. So these are all side chains which is having a example which I already discussed, and must be considered in terms of different side chains, probably because of the specific antibodies are directed to common chemical structure shared by all. Recently, CDC has given published a paper which has said that people always say that they are sensitive to the penicillin. 10% of the population are reported, but actually it has found that is less than 1% of the population is truly allergic. That means 10% of the patients reported penicillin, although 90 to 99% can tolerate the penicillin. Next. Coming out of the radioactive radio contrast media reactions is anaphylactic, direct mast cell activation, delayed reaction due to the type 4 hypersensitivity, and reaction rate from ionic contrast to the non-ionic contrast. No evidence that sensitive to seafood or iodine, predisposed to cross-reactive with RCN reactions. Next. So there are some risk factors more in the females and asthmatic conditions, cardiovascular disease, and pre-reaction to the RCN. Management, non-ionic RCN, pre-treatment always given before the exposure with a prednisolone 50 milligrams, 13 hours, 7 hour, 1 hour prior. And diphenhydramine is 50 milligrams 1 hour prior. Ephedrine, albuterol, next. Coming on to the aspirin exacerbated respiratory disease associated with asthma, rhinitis, sinusitis, nasal symptoms with NSAIDs, rhinorrhea, conjunctivitis, bronchospasm, and rarely flushing urticaria, GA symptoms, laryngospasms, hypotension, dependent on COX-1 inhibition. COX-2 inhibiting generally is safe. Next. So this is again with your angiotensin ACE inhibitors. There is a cough and angioedema. I am little fast because time is very up. Dr. Saibal, can I take another few minutes?
Yeah. I think we can have another 5 minutes more.
Next. So how to assess the reactions? A detailed clinical history of reactions like symptoms, a precise description of the morphological and chronological of the reactions is very, very important. The route of administration given in the oral or IV or IM, the role of drug metabolites, and the presence of cofactors and a co-prescribed drugs may accelerate or slow down the onset of progression of a reaction. Next. A detailed clinical history is very, very important, and a confirmation of the diagnosis based on the reliable in vitro test and standardized skin test and a drug provocation test will be discussing shortly. Next. So this is an algorithm just to give a clear picture. When you take the history of the possible adverse reactions and compatible with an allergy reaction, if it is yes, skin test or an in vitro test is possible. And if it's a severe reaction, that is considered contraindication test for the skin test. It should be always done in the higher dilutions. And if it's a non-severe reactions, you can do if it's a non-immediate, you can do a patch test. Intradermal test is also advisable. And if it's an immediate non-severe reactions, then you can do a skin prick test, intradermal test. And if the skin test in vitro test is not available, then you do a drug or a clarification of event important and a provocation test possible that can be done with a hospital-based services. And if it's a provocation test adverse reaction confirmed, then it's a drug avoidance. And if it's a no drug avoidance, and he can continue with the treatment. Next. It is algorithm found in the children. If it's an immediate reaction, history with the immediate reaction, the skin test is the advisable, either the in vitro test, or if it is a negative in vitro test, then you can do the provocation test. If it's a non-immediate reactions, it's a mild exanthemas, then you can do a directly provocation test. And if it's a negative, there's no drug avoidance, you can continue the treatment. If it's a confirmed, then it's a drug to be avoided. Then if it's a non-immediate reactions of severe exanthemas and skin test like patch test or intradermal test is confirmed. If it's a very severe scar, then drug avoidance is the choice doing any test. Next. Coming on to the criteria for diagnosing anaphylaxis is highly likely when one of the following three criteria are fulfilled. Like acute onset of the illness, like it may happen in seconds of the minutes and to the several hours with involvement of the skin, mucosal lesions, or both generalized hives, pruritus or flushing, swollen lips and tongue, uvula, at least one of the following. Respiratory compromise and a reduced BP. Next. And another is two or more of the following occur rapidly after exposure to likely allergen for the patient. Involvement in the skin mucosal tissues, respiratory compromise, reduced BP associated with the symptoms, and a persistent GI symptoms. Next. So test for a delayed type of drug hypersensitivity. Is it an in vitro test? Either you can have a proliferation lymphocyte transformation test or a cell surface activation markers CD69 upregulation, which is more or likely in research mode. And you can do a cytokine like Th1 cytokines, interferon gamma, IL-2, TS2 cytokines like IL-5, IL-13. Then cytotoxicity, that is a granzyme BCD107. In vivo test is either you can do the skin test or a provocation test. Next. Skin prick test or intradermal test are useful for the diagnosis of specific IgE-mediated type 1 reactions. More preferably, we do this intradermal test. Next. Indicated for the specific IgE-mediated conditions only. It is not indicated for the identification of IgM or IgG-mediated immune conditions or in the SJS or 10 or address, but patch test can be useful in these conditions, can be useful in documenting the THS. Next. Patch test, very useful for the diagnosis of various delayed, that is type 4 cutaneous exanthematous, but generally not helpful for the diagnosis of SJS and 10. And the measurement of histamine less than 1 nanogram per ml and tryptase more than 5 nanogram per ml levels are useful. Confirm the acute IgE-mediated reactions, particularly anaphylaxis, and a blood count. Next. 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 So this is one of the, just a cartoon to give you a clear picture. So when the hapten protein is come in contact with anti-inflammatory cells and which is sensitized in the T cell, and that particular zone, which we call it as lymphocyte transformation test, is done. And because of the interleukin 4 is secreted and stimulating the B cell, where this IgE is released, where this immunoassays are done. One is by skin test, where you can see this mast cells degranulation, which is done because of the IgE binding with the drug and releasing the mediators, and skin test is positive. Whereas in basophil activation test, which is done, activating the basophils because of the hapten, which is binding on the prefixed IgE molecule on the base. Next. So key features of acute management: stop a suspected drug, treat the reaction, identify and avoid a potential cross-reacting drugs, and record the precise details of the reaction and its treatment. If possible, identify a case alternative. If necessary, consider desensitization, which is rarely indicated because number of alternative drugs are available. Next. So decision path with a patient with drug allergy. If an alternative drug available and effective, treat with alternative drug. If no, then a reliable test is available. Do the test, and if it's found to be no, then the pre-medication or a provocation test or both has to be done. And if it's a test is negative, then continue with the drug. And if it's a positive, desensitize, then treat. And the pre-medication or a provocation test or both are the reactive, then desensitize. The non-reactive, continue with the treatment. Next. So ultimately, you have to do a patient education is very, very important. Make the patient aware that he is responsible for future avoidance of the culprit drug. Encourage a patient to wear an allergy bracelet stating the cause of the reaction. Warn the patient to avoid over-the-counter medications where precise constitute are unclear. SPT ID patch test results show a positive ADR. Negative results may become positive over a period of time. Therefore, any patient who comes to you and asking for a list of drug to be done, please straightly avoid, and you can say that this test holds good only for a short period, which we don't know. It may be 1 day or 1 month, and this test may not be holds good after a long time. So this is very, very warning signal, because most of the patients who are having a history of drug allergy, they come for a drug test and which is not possible to do it. And they also do the specific IgE test for drugs, which is also not effective in giving a clear message. Thank you very much, sir.
Thank you, Dr. Nagendra. I think that was a very comprehensive talk, and we can have the Q&A session at the end. So we'll move forward to our next speaker. Our next speaker is Dr. Krishna Mohan. Dr. Krishna Mohan, he is a consultant in pediatrics, which is specialized in pediatric allergy and the Kerala Government Health Services. He's a state chairperson of the respiratory chapters of the Indian Academy of Pediatrics, Kerala, editor and treasurer of the National Allergy Chapter of CIFP, the National EB member of the respiratory chapter of the CIFP in 2021. He is the State Joint Secretary of the IAP Kerala in 2021-22 and State Chairperson Allergy and Immunology Chapter in Kerala 2019 and 2020. He has many accolades, and just to name a few, he is the Best Academic Activities Award recipient in 2016 IAP Kerala. He has received state level Best Doctor Award from Award 2019 from the Kerala Government Medical Officers Association. He's the chief editor of the Essentials of Pediatric Allergy and Immunology in 2021. And he's associate editor of the textbook of the Pediatric Allergy and Immunology. And also the academic editor of Partha's Handbook of Pediatric and Adolescent Practice by JP Publishers. So we have in today's evening Dr. Krishna Mohan with us, and he would be enlightening us on a very important topic, that is the environmental control for prevention of allergic diseases. It's over to you, Dr. Krishna Mohan.
Thank you, sir. Am I audible, sir?
Yes, you're audible.
Yeah, the screen is visible.
Screen is also visible, but it has to go into the presentation. Now it's fine. Now it's fine.
Okay.
Yes.
Okay, sir. So at the outset, let me thank Sanofi as well as my dearest friend, respected Dr. Saibal Moitra, and my most respected teacher, Dr. Vedantan sir, for giving me this opportunity. So without wasting much time, we will go on to the topic proper. So today, I will be talking for the next 20-30 minutes. I will be talking about the environmental control measures in allergy. So we already discussed about food allergy and drug allergy, and for any type of allergy, it is an interplay between the individual immune system, environmental factors, and the genetic makeup. We cannot do much with the individual immune system or the genetic makeup, but with the environmental factors, we can do something so that the future allergy can be prevented. So we all of us know the culprits are the allergens as well as the different irritants, which are the main culprits leading to allergic diseases. So allergens, we know they are low molecular weight proteins capable of inducing IgE antibodies and leading to an allergic trigger. So we have indoor allergens as well as outdoor allergens. And first of all, we will discuss about the indoor allergens. We have a lot of indoor allergens, but among those, these four are the most significant one as far as in our place is concerned: dust mite, cockroach, the pet danders, and molds. So what I am planning to discuss is I will be telling a few words about each allergen and what are the different preventive measures that we can take so that the allergy can be controlled in one way or other. So dust mite, it is a very, very important allergen, especially in our place in India, in all tropical countries. And there are different species of dust mite, but among those, these three, that is the dermatophagoids, Veronicines, dermatophagoids, Farini, and the Euroglypus, these three are the most significant ones as far as allergic diseases are concerned. We all know they are microscopic organisms, feeds on human scales and debris, and the most allergenic particles are mainly the house dust mite fecal pellets. And even though there are more than 40 different types of allergenic components for this house dust mite, among these, 3 of them are important. That is the DER P1, P2, and P3. Now coming to the different preventive measures, what can we do? So one important thing is that hygiene. So what we require is that it should be seen that you are wet mopping the floor. And vacuum cleaning also is important. And wet mopping as well as regular vacuum cleaning is extremely important. One important point to understand is that humidity, the atmospheric humidity, is a very significant factor which affects the growth of the house dust mite. So they thrive in humidity which is more than 70 to 80%. So if you do something to decrease the humidity to less than 50%, you will be able to control the house dust mites to some extent. So you can use a dehumidifier. You can use an air purifier, which will in some extent help in controlling the house dust mite. And one other thing which we can do is that you replace your leather or fabric furniture and replace them with wooden or plastic furniture as far as possible, so that the reservoirs of house dust mite, like these leather and fabric furniture, will decrease. And the bedroom carpeting and wall-to-wall carpeting, even though it is not a usual practice, but especially in the Western countries, this wall-to-wall carpeting and all these are done. And as far as possible, try to avoid these. And another option is putting an impermeable covers for pillows and mattresses. You can use an impermeable covers like a plastic or vinyl covers with zippers, and take care to paste a electrical tape or a duct tape over the zippers so that it is 100% blocked. And in our country, in tropical countries like India, where we have a luxury of sunlight, sunlight is a very, very useful thing that we can try to prevent this house dust mite. So dry heating, we can expose the beddings as well as mattresses to direct sunlight for 5 or more hours, and that is very, very effective. And after exposing to the sunlight for 5 hours, we can put the impermeable covers. And another option for dry heat is ironing the clothes at all. And we can also wash the bed sheets, clothes, cloth doors, etc. in hot water at temperature more than 60 degrees Celsius for at least 30 minutes. And take care to change the bed linen at least weekly. What about these measures? What does the evidence tell us? Will using a particular house dust preventive measure help an allergy patient? So what has been found out is that it's very, very difficult to implement a full dust mite regimen, doing everything possible. And partial regimen or partial implementation may not lead to dramatic improvement. So what we can advise is that we have to tell the patients the importance of avoiding these allergens. But at the same time, we should remember that doing one measure may not be enough. So a multifaceted approach for house dust mite control may work. Now coming to another important indoor allergen, cockroach. So it is significant, especially in the inner cities. It is strongly linked to asthma in inner cities. We have 3 main species in India: this Blatilla germanica, Periplaneta americana, and Blatilla orientalis. The important allergens are BLA G1 and BLA G2, and it is derived mainly from the saliva and fecal pellets. So what all things we can do to prevent cockroach? First and foremost thing that we should remember is that we have to remove the sources of food and water of these organisms. So as far as possible, take care to take food only in the dining room, not in any other place, not in the bedroom, not in the other rooms. You do not take further. And you try to seal cracks in the floors and walls where these cockroaches may hide. Frequent cleaning is very important, and regular extermination using chemical treatment is also advised. So that is about cockroaches. Now, another important indoor allergen is the pet danders. So pet danders, mainly we have the most commonly used pets that we have are the cats and the dogs. Among these, as far as allergy is concerned, cat is a more significant allergen than a dog. So all of us know cat belongs to genus Felis catus, and the important allergen from cat is what is known as the FeLD1. Another important thing is that males produce more FeLD1 than female cats. It is seen in the saliva, urine, sebaceous glands, and one important thing is that it is having a high adhesiveness. So our skin, our dresses, and a lot of things will carry these allergens whenever we come in contact with these things. And we should remember cat dander is found for 3 to 4 months even after removing the cat. So as a measure, you are telling you just remove the cat from the home, but even after months, that allergen may persist in the surfaces which have come in contact with the cats. So that one point we have to remember. These allergens are very light and remain suspended for very, very long periods. So compared with the cats, the dog dander allergy is less prevalent, and CAN F1 is the major allergen. So this is a controversial statement. Sometimes we feel that this is controversial. So do pets have a protective effect on allergies? So studies have proved that it depends on the time of exposure, the timing of exposure. Studies have proved that if you have an exposure in the early infancy or even in the prenatal period, has some protective effect and not later. So what all things you can do to prevent this pet dander allergies? So removal of pet from home, at least in some cases that will be difficult because many times we will be too much emotionally attached with the pets. Restricting indoor entry is one thing that we can try, or at least make sure that there are no pets in the bedroom. Washing the dogs regularly is okay, but cats, I don't know. It is not that easy to regularly wash cats. And we can, just like in the house dust mite thing, we can use mattress covers. We have to use a regular vacuuming and bed mopping. And one thing that we can do is that make sure you're washing hands immediately after coming home inside, after touching the pet, and you change the clothes after being with the pets. So these are some of the practical protective measures we can do to prevent the pet dander allergy. Another important indoor as well as outdoor allergen is mold. Mold is an allergen which is significant both in the indoor as well as outdoor. And the significant ones that we have in our place are Penicillium, Aspergillus, Alternary, and Cladosporium. And it can cause both perennial and seasonal symptoms, and is the most important thing which favors the mold growth is moisture. So it grows best in moist places in optimal temperature of 18 to 32 degrees Celsius. So what thing that you can do to prevent molds? First and foremost, eliminate the sources of dampness. So opening your doors and opening your windows and allowing the sunlight to come in is one thing that you can do to eliminate a source of dampness. Dehumidifiers, as I already told, which keeps the humidity below 50% will help. And repair the moisture prone areas, especially the bathrooms where there are leaks. You can try using an air filter, which are the HEPA filters in the living area, and make sure you change and clean the AC filters regularly. That is a reservoir for, it's an area for moisture. It can lead to a mold growth. That is about the major indoor allergens. Now coming to outdoor allergens, and among the outdoor allergens, the most important one are the pollens. So pollens, for human beings, it is a source of allergy, but for the plants and trees, they are the male genetic material for reproduction. And as far as India is concerned, we have two major pollen seasons in India. Mainly the tree pollens between February to April, and grass pollen between September to December. So this is another question which I would like to ask you. Are all pollens equally allergenic? So we should remember they are not. We do have these anemophilous pollens and entomophilous pollens depending upon how the pollination is taking place. So the anemophilous or the wind pollinated pollens, that is mainly seen in the trees, weeds and grasses. They are usually having less attractive flowers, but the pollen productivity is high. Those are the ones which are clinically relevant compared with the entomophilous or the insect pollinated ones which are having the attractive flowers, but they are not that much allergenic compared with the anemophilous flowers. So these are some of the commonly seen allergenic pollens in India. Prosopis, ricinus, and lot of things are including amaranthus, coccus, parthenium is a grass. All these things are very, very important allergens, allergenic pollens seen in India. But one important concern, unavailability of local aerobiological data regarding pollens and spores. We do not have sufficient data. For me, practicing in Kerala, I don't have a sufficient data about the pollens around my area. We do not have botanists who are qualified or are trained in tracing this out. So it is really challenging for the allergists to select an aeroallergen panel. This is one important article, a very interesting article from Vedantan sir and team, and the appraisal of allergic disorders in India. So that is a very, very important concern. This is another important point, diesel exhaust particles. Many times we would have seen a tree or a plant in our village, native village, was not causing any problem for us. But when we came to our urban area in a town or a city, it is causing allergy. So this may be the culprit for that, diesel exhaust particles. So pollens become more allergenic when they are grown in an urban environment. That is by the influence of this diesel exhaust particles and major allergens, which is due to the air pollution, the allergenicity of pollens can increase even up to 50-fold. So what can we do to prevent pollen allergy? Some practical points: keep windows closed, especially when the local pollen count is high. Wash face and hands after entering house to remove the pollens. Change and wash clothes exposed to pollen. Wear face mask. Nowadays, it is very common for preventing COVID. We are using face masks. That may be helpful in preventing pollen also. Air filters, air conditioners can be used. And as far as possible, for an allergic patient, control timing of outdoor exposure. Try to avoid outdoor exposure, especially in times of high pollen count, especially in the early morning hours. Now coming to the last part, air pollution and allergy. So not only the allergens, the irritants also can lead to an aggravation of allergic symptoms or the precipitation of allergic symptoms. We should remember, worldwide, India has one of the highest concentration of air pollution caused by the different irritants like vehicular exhaust, biomass, and fossil fuels. So these are some of the common air pollutants. We have the particulate matter, carbon monoxide, nitrogen dioxide, sulfur dioxide, and ozone. So this is one important source of pollution, vehicles. So the vehicular exhaust, especially the diesel vehicles, for sake of saving the money that we spend on petrol, we will be preferring, some of us will be preferring a diesel vehicle. But as you can see from this study, as far as air pollution is concerned, a petrol vehicle is very less polluting compared with the diesel vehicle. It is less polluting. And this is one interesting study by our respected Paramesh from Bangalore around the traffic density around school and prevalence of asthma. That you can see in this picture, the prevalence of asthma is definitely high in a place where there is a heavy traffic compared to the place where there is a low traffic. So that is a direct relation between air pollution and asthma and other allergic diseases. Another important thing is the environmental tobacco smoke. So this ETS or environment tobacco smoke exposure, it has been noted to be the single most important risk factor of severe asthma in the inner city population. So the particle size is very small, so it can penetrate very easily and can lead to increased prevalence of the respiratory infections and the allergic diseases like asthma and allergic rhinitis. Another important thing, especially in our scenario, especially in the villages, is the biomass fuels. Still, we are depending upon the biomass fuels like the firewood, cow dung, etc., which can lead to release of particulate matter, carbon monoxide, sulfur dioxide, nitrogen dioxide, formaldehyde. An allergy patient is a chronic disease having a lot of relapses and all. Many of the patients as well as the bystanders will be depressed. So they will be very devotional. So they will be burning incense sticks. But we should remember, even the incense stick is an irritant which will release a lot of polluting gases like carbon monoxide, carbon dioxide, nitrogen dioxide, and SO2. So that is also important, especially in our country. Mosquito coils, as we see in this picture, burning one mosquito coil in a closed room is producing the same amount of particulate matter as around more than 100 cigarettes. So that is very, very important. Before I finish, I would like to talk about two equipments that we can use in allergic patient houses: air purifier and dehumidifier. So air purifier, as you can see, is nothing but a box which contains a set of purifiers, a set of filters. You can see in this picture. So air passes through this and a series of filtration happens, and what comes out may be a somewhat purified air. But not all air purifiers are the same. So there is something called the MERV rating, minimal efficiency rating value. So that is the thing which will help you to guide you in choosing which all air purifiers you are expected to buy. So MERV value means that how far the filtration is happening. So you should remember, in asthma, the culprit allergens, the size of the culprit allergens is less than 3 micron. So only if you are using an air purifier which is able to filter particles less than 3 micron, it will be somewhat effective. So what is said is that any air purifier with an MERV rating more than 16, that is 17, 18, 19 or 20, that is what is expected to be brought in a house of a allergy patient to get some effectiveness. So this is what is called as the MERV rating. There is another criteria called the clean air delivery rate, or the CADR. So what is it? So I would like to compare this with an air conditioner. When you want to buy an air conditioner, you decide it based upon certain criteria. You will be thinking about the room size. The room size, if it is a big room, you want a 2-ton or 1.5 ton AC. And if it is small size, you can even use a 1 ton or a 0.5 ton. Just like that, an air purifier also has a value called as the CADR, or clean air delivery rate, which depends upon the breadth, height and length of the room, as well as the desired air exchange rate, which is around 3 to 4 per hour, and the cleaning efficiency. So what is the acceptable CADR for allergy patients? It should be more than 600 cubic feet. So these are some of the important factors for air purifiers. As I already told, CADR depends upon the room size. MERV, which will guide you because it depends upon the size of particles that you want to filter. The location of unit is very, very important. What happens usually is that there will be an air purifier and you will be keeping it at one corner. Usually what is seen is like that. You will be keeping it one corner and below the table or below the bed, something like that. That is not recommended. What is recommended is that you have to keep it in at least in the center of the room so that it can take the air freely and release the purified air. Do not use ozone generating air purifiers, because ozone itself is a air pollutant, which is irritant, so it is not advisable. Activated carbon layer type of air purifiers can be tried, and always make sure you are periodically cleaning the filter or changing the filter of air purifiers for best results. Power consumption also, just like for an air conditioner, you have to use a higher rated for a 5-star for an AC like that. You have a higher star rated air purifier for better power saving. So what about air purifiers in allergies? In simple terms, one important thing to note is that even though I have discussed all these things, they do not remove dust mite allergens effectively. But the dust particles, the reservoir of the dust mite, the dust particles can be removed somewhat effectively. So that thing you have to remember. And one point about dehumidifiers, as I already told, for house dust mite as well as for the molds, humidity is an important criteria for their growth. They require a humidity of around 80 to 90%. So if you do something to decrease the humidity less than 50%, the percentage of house dust mite as well as the molds will come down. So this is a dehumidifier, the structure of a dehumidifier. What it is doing is that it decreases the humidity of the atmosphere around you, especially if you're using it inside a room and the target humidity is less than 50%, 35 to 50%. It will help in long run to decrease the allergic reactions. So that is in short about the different environmental control measures. So what I have tried to cover is about the various indoor as well as outdoor allergens and the different irritants as well as the different pollutants and how you can try to prevent these things. And along with the pharmacotherapy and along with the immunotherapy if you're doing, if you are using the allergen avoidance measures properly, it will definitely help to decrease your allergies. So thank you so much for your patient listening.
Thank you, Dr. Krishna Mohan. That was really a very elaborate and well conceptualized talk. And I think it leaves very little room for any questions because you have so nicely elaborated all the points and tenets of the environmental control. So now we move ahead to the last talk. And though there's a time constraint now, but it's a very important talk. And this talk is basically on the allergen immunotherapy, and which will be taken up by Dr. K.K. Vedantan. So he would be basically giving us the ideas in the nuts and bolts of the immunotherapy, like how it is being done and what are the various basic concepts of the immunotherapy. Since it is an important and treatment and part of any allergic diseases, namely the nasobronchial allergies. Okay, so it's over to Dr. Vidal.
Thank you, Dr. Saibal. Can you hear me?
Yes, I can hear you, sir. I can hear you.
Okay, great. I know it's getting late for all of you, so let me move on. This is an important topic, like Dr. Saibal was saying, because this is probably one of the most important topics that allergists would like to hear about and get expertise in. And this is a field that can be quite complicated at times, but we will go ahead and try to keep it as simple as well as informative as possible. And this talk is basically designed for people who have not been doing allergen immunotherapy. So if people are doing it, it may look a little bit redundant, but just go ahead and put up with these basic things I'm again going to talk about. Now, as I mentioned before, the definition of allergy is an altered reaction. It's an immunological reaction. It's a reaction against harmless substances to most of us, and the resultant could be protection and damage. So allergy is an immunological reaction. It's an exaggerated reaction. It's an altered reaction against substances that are harmless to most of us. Dr. Krishna Mohan showed beautifully all the different allergens, but if you look at it, they are all very benign. Dust mite, cat dander, dog dander, molds. People who don't have allergies even do not pay any attention to it. These are benign things. We don't try to see where is the dust, where is the mold, where is the cat dander. But people who are sensitized to it, people who are allergic to those things, have a huge issue with those things. So just an exposure to a benign agent can provoke a significant allergic inflammation in their tissues, and depending upon the target organ, they can have significant symptoms. And just to briefly, A to P word is called genetic state. That is a state of where you are prone to develop sensitization. Sensitization is an immunological state where you have the property, your body has already been able to detect the antigen, react against it, produce the IgE, specific IgE, but you may not have any symptoms. You are in the ready state, but so you may be sensitized, but not allergic. Allergy means clinical state. You have to have symptoms. When I say I'm allergic, that means I'm having nasal symptoms or eye symptoms or skin symptoms. If I say that person is sensitized, that means it's an immunological state. If I say that person is come from an atopic state, he is a genetic state. He may not even be sensitized yet. So what are these T cells and what are these B cells that we are going to talk about? These T cells are basically lymphoid, from the lymphoid series. These lymphocytes, these are naive lymphocytes that get trained in the thymus. These lymphocytes enter the thymus where they are exposed to the self-antigen. If they recognize the self-antigen, then they undergo apoptosis. That means they are killed right there. They do not want your T cells to recognize your own antigen. So if they does not recognize the self-antigen, they graduate and they come out of these thymus as graduated T cells or different. That is what we call as a T lymphocyte. These T lymphocytes are the backbone of your immunity, and 70% of the lymphocytes are T lymphocytes, and they sort of circulate all over the body continuously. And where are the T cells found? They are found not in your blood, actually in the lymphoid tissue, in the lymphatic follicles, lymph nodes, in the lymphatic channels. Then you have the B cells, which the reason why it is called B cells is because it is sort of a little bit of a misnomer almost, because the chicken has this the organ called bursa fabricius, which is analogous to the bone marrow, where the lymphocytes are produced in the humans. So they call it bursa fabricius or B cells. That's what it is called. And B cells are basically responsible for immunoglobulin synthesis, and they also mature in the lymph nodes. So lymph nodes are very, very important for us. Lymph nodes is where the reaction takes place. Lymph nodes are the places where the T and B interaction takes place, and lymph node is where this T and B interaction takes place when you have this allergic reaction like I mentioned before, and that's what the diagram shows. I'm not going to go through that again. Now, if you look at allergy per se, it is actually an epithelial cell disorder. If you look at the type of immune cells that are involved in an allergic reaction, it is not eosinophil, it is not Bast cell, it is not IgE, it is T cell. That is the one that is responsible for the whole inflammation. It is a T cell driven mechanism. It's a T cell disorder. So no medications will work on T cells. No medicines are there. You have got steroids, you have got anti-leukotrienes, you have got antihistamines, they work at all at tissue levels, but nothing works on the T cell. But we know T cell is the culprit. So what works on the T cell is allergen immunotherapy. Allergen immunotherapy is the only modality that acts on the T cell. And what it does to the T cell, it converts the T cell to what we call as a T-regs.
Hello. Yeah, I think Hello.
Dr. Moita, we can hear you. I think
Okay, I think
there's
we're
some
not
issue,
able
yeah,
to issue
with Dr. Vedantan's internet.
Dr. Vedantan, can you hear us? Dr. Vedantan?
He got dropped, Dr. Moita.
Issues. Let me just check with him. Sir, can you hear us, sir? Dr. Vedantan? Oh, yeah. Yes, right. Okay, great.
Can you hear me?
Yes, yes. Now,
There was some internet problem. It got disconnected.
yes.
Okay.
Okay, sir.
Sorry.
Please.
Sorry.
No, sir. No, it's okay, sir. Please.
So basically, going back, allergy is a T cell disorder. So what is allergen immunotherapy? It is a way of modulating the patient's immune response. It is the way you train the patient's immune response the way you want it. And what you want is for the T cells to be suppressed. And how do you do it? You confuse the immune system. How do you confuse the immune system? Is to go ahead and give heavy doses of this antigen. If you give small doses of antigen, which happens naturally, if you look at the natural set of events, what's happening in nature, we are exposed to all these pollens, dust, mites, and all that we talk about. But if you look at the amount of antigen that we are being exposed to, the amount of antigen that is causing the allergic response is extremely small. Extremely small amounts of exposure is provoking the allergic response. But if you overload the immune response, overload it by giving huge doses, that's why we go, when we say the therapeutic dose for dust mite is 20 micrograms or something like that, whereas the exposure could be 0.01 or something like that. So we really overload the system. So when you give these huge doses, it actually modulates the immune response. By giving that heavy dose every other week or every day through sublingual or every other week through subcutaneous route, you just quieten the whole immune system, and that is what modulation means. And AIT targets the lymphocytes, and creates these T-reg cells, which regulates or suppresses the immune response, and that actually translates to modifying the patient's symptomatology even after exposure to the relevant antigen. And so the mechanism of AIT is basically to convert the the T cell to Treg cells, which in turn, what it does, first thing it does, it actually will reduce the what we call as the release of the mediators from the basophils and mast cells. They first suppress that, and that is called decreased local anaphylaxis. That is the first thing that happens. Then they also will reduce the mucus production. Gradually, they reduce the IgE production, and then they also increase the IgG4 production. All these changes that happen immunologically actually will translate into significant suppression of the allergic response, which in turn will give you clinical relief on a long-term basis. And because it is an immunomodulator and you continue the suppression for several years, the immune system will get so well trained that even after you stop the immunotherapy, it will continue to work like that for the next 10 years, maybe 15 years, depends upon the particular individual and particular genetic makeup. So if you look at this diagrammatically, it looks very, very simple and straight, but it is that the immunological changes don't happen this simple like as it is showing. But the message here is immunotherapy, unlike what we think, it actually starts working from day one or maybe in the first week itself. We think, oh, it won't work for 6 months. That's what we tell the patient. And clinically, it may not show up the effect, but actually, immunologically, it starts working very fast. So what it does initially is suppress that local anaphylaxis. And then that is the early decrease in the mast cell and basophil activity. And the second thing that does, it induction of the Treg cells, and then decrease in the tissue mast cells, decrease in the eosinophils, decrease in the release of mediators, decrease in the late phase response. The last thing I said is probably the most important thing. Decrease in the late phase response. As you remember, late phase response is a hallmark of remodeling. Late phase response is where there's an intense inflammation that is occurring. Late phase response is where there is maximum amount of tissue damage and tissue repair. So gradually, if you institute immunotherapy, what it can do is actually can slow down the remodeling of the airways and actually can reverse the remodeling of the airways. And that is one of the reasons why clinically we have seen in our own practices, which many of you have, around third year of immunotherapy, even in asthmatics who are allergic asthma, I'm talking about, who are on inhaled steroids as well as LABA and other medications, we are able to reduce these medications by almost 60 to 70%. Still do well, because what you are doing is reduction of the late phase response, and that is what causing the reducing the inflammation. Once you reduce the inflammation to the T cell, you don't need inhaled steroids that much. You can actually manage with less. So in one way, I feel personally, this therapy is superior to any biological that you can think of. Biologicals are heavily marketed. They are very well targeted. But what do? Do they reduce inflammation? No. They just go and target that particular mediator that is going like an interleukin 4, IL-4/13. They just target that particular and decrease. But what is immunotherapy doing? It is overall reducing the overall inflammation of asthma. And that is why immunotherapy has a major role. Unfortunately, it has not gotten the credit that it deserves. If you look at the GINA guidelines, It says immunotherapy last at stage 3. Stage 3 has a lot of remodeling that has already occurred. The disease has been going on 15 years. You can't go and reverse it much. So when does it work? The immunotherapy works when the disease is young, patient is young, when the remodel is young. That is when it is highly effective. Unfortunately, the guidelines doesn't say that. Irrespective of whether the guidelines say or not, we as allergists, we don't have to worry about it. We know how it works. So our job is to institute immunotherapy early in the game, not late in the game. So when does it work? When you select the patient properly, when you select the right antigens, when you write the right composition, and when you administer it right. So proper selections are extremely crucial for the efficacy of immunotherapy. When it doesn't work, poor patient selection, wrong antigen selection, poor quality of the antigens, when you have other comorbid conditions. A lot of adults have COPD and many other cardiac issues and all that type of stuff, and it won't work. So a young patient, say like I have an 8-year-old boy, 8-year-old child with seasonal allergies, seasonal asthma is the best candidate. Or a 8-year-old, 10-year-old who has had allergies, whose allergies are progressive. He has also got neosensitization coming on. He's the best candidate for immunotherapy. A patient 50-year-old has got a comorbid condition, already has significant asthma plus COPD, has some skin reactivity. He's not a candidate for immunotherapy. He's not a candidate. He's a wrong selection. So what has happened over the years is patients have treated skin testing. They have treated skin tests. They have not treated patients. So when you do treat skin tests and not the patient, it won't work. And that is why immunotherapy fell into disrepute. So patient selection was wrong, antigen selection was wrong, and the quality of the antigen was also not good. So now we have come a long way. We have standardized about 18 antigens in US, and we know exactly what dose. We know the therapeutic dose. Just like we use immunotherapy now, just like we use antibiotics. When I was doing fellowship or when I was in early practice, I would just do shot in the dark. I would say, okay, I am going to add 1 cc of this to half a cc of that and this and that. It still worked. Now I don't do that. I say, I know you need 10 micrograms per injection. I'm going to give you 20 micrograms of dust mite every month. I'm going to give you 50 micrograms of the grass pollen. I'm going to give you so many milligrams of the cat dander, so many milligrams of the dust mite. So I am writing a very evidence-based prescription. So this is a huge improvement. So when you have that type of knowledge now, when that type of approach there, chances of you getting success with immunotherapy is extremely high. Extremely high. So whom do you treat? As I just told you, young patient, mild disease, allergic disease, compliant. And whom you don't want to treat is severe long-term disease, elderly patient, comorbid condition, non-allergic disease, non-compliant. So if your selection is not good, your result is also not going to be good. And this is what I mentioned. These are the typical doses I know that you can treat. Very easy to remember, 20, 50, 40. That's all you have to remember, numbers. And you know exactly how it comes. You write a prescription. And do not send the skin test sheet to the antigen company to make it up. You write the prescription and let them make it up. And that is how the immunotherapy works. So write a prescription and administer the medicines right. And you can write prescriptions separately for sublingual, you can write prescriptions for subcutaneous. I am not getting into those details. So summary is it's a very, very powerful immunomodulator. It changes the climate from TH2 to TH1. Selection of antigen, selection of patients are crucial. And for the first time, we are giving it just like we give antibiotics. And immunotherapy does something wonderful. It actually reduces neosensitization. That means immunological progression by 50%. This study showed that when you have immunotherapy compared to control group, immunotherapy blocks neosensitization. That is, children getting newer sensitivities by at least 50%. And cost-wise, if this is the United States figures, and because you are treating the late phase reaction, because you are reducing the need for all those incredibly expensive steroids there, inhaled steroids, because you are giving it less often and it still works, once a month is enough on immunotherapy after the year 2, you are saving 60% on immunotherapy. That is why most of the insurance companies in the US cover immunotherapy because they believe in it. There's a lot of literature to support it. And this is showing that even after you stop it, it works as well. So it is extremely effective, long-term, both clinical and immunologically beneficial. And this is showing shift to the left, where it is showing subcutaneous immunotherapy reducing the need for these inhaled steroids, and same thing going right here, ICS reduction, significant reduction. And so the summary is prevents neosensitization 50%, less expensive than pharmacotherapy, extremely effective modality, even after stopping it continues. Wow, very small example, 25-year-old, seasonal allergies, seasonal asthma, history of disease progression. What is progression? That is, the disease progresses. In spite of medicines, he is having symptoms. In spite of medicines, he is having newer symptoms. In spite of medication, his symptoms are not 100% controlled. Initially he was controlled, then it's coming back. And skin testing is showing significant inhalant positive, and if you repeat in these tests, they may show bigger reactions later on. Good correlation. So young guy, seasonal problem, young disease, he's a good candidate. And types, skit, slit, oral, percutaneous. Skit is definitely more efficacious. Slit is getting more popular because of the safety. Still, dosage is not very well established. But in India, we don't have the tablets yet. Once you have the slit tablet, it will make a huge difference because it will be standardized. Until then, we are just playing around with these drops and all that. It still works okay, but subcutaneous is extremely effective. 60-year-old, smoker, COPD, asthma, few positive skin tests, he is not a candidate. So there's totally poor correlation. So this person is not a candidate for immunotherapy. And safety, both cause reactions, but sublingual is extremely safe, has a very good safety profile. There is no death involved due to sublingual, but there have been systemic reactions due to sublingual immunotherapy, but no anaphylaxis. Subcutaneous, if it is given rarely, there are a few cases of anaphylaxis, systemic reactions, about 18%, but deaths are very few, maybe 2 or 3 in a million or something like that. It's very rare. But if you take proper precautions, even that can be minimized. So the main precaution you have to take if you are giving subcutaneous immunotherapy is to make sure one thing is stable, that is asthma. If you just take care of a person's asthma, he is okay. If you don't take care of the asthma, if the asthma is unstable, and if you don't pay attention to the stability of the asthma, and you give the allergy injections, if he has a reaction, chances of him dying is very high. So make sure every time you give allergy injections, you inquire about asthma. How are you doing last night? Did you have any extra inhalers and all that? Make sure you take peak flow meters at least twice or 2 peak flow readings before any type of allergy injection, and make sure they wait for 30 minutes. And after that, again, repeat the peak flow. And all of them have to carry EpiPen or one of these adrenaline with them, because systemic reactions can occur not after only 20 minutes, 30 minutes. They can occur 2 hours later also. And sublingual always should be started at the doctor's office. and no food or drink. It says 5 minutes, but I think I had read it somewhere 30 minutes. And keep the dose for 2 minutes, it says, but I made it 1 minute because I myself kept it for 2 minutes. I felt it was too long. 2 minutes is too long. And you don't need 2 minutes. Half a minute is enough, because this there is so much. It is almost like intravenous. You put it under the tongue and it will just get absorbed right away. And there's a limit to it. There's a limit to how much it will take inside the sublingual, because the lymphoid follicles there cannot overload themselves. So the dosage of sublingual that is given sometimes can be a whole lot for the thing. So you don't have to. That is why one of the things you could do is give it every other day after about a year or something like that, and it works beautifully. And you have to make sure the asthma is completely controlled, even for sublingual, when you want to do that. And this is emergency crash cart everybody should have. Epinephrine is a prime thing that you have to have, and antihistamines. And so when you have an acute reaction, don't give Evil, don't give Efcorlin, don't give Soliquatlef. Give epinephrine, second epinephrine, third epinephrine, and then you can do all the other stuff. So allergy immunotherapy has its own risk. And I forgot to tell you, sublingual can cause some local reactions of certain burning sensation in the mouth, some painful abdomen, and a little bit of swelling, some of the buccal mucosa and all that. If you persist, it will all go away. What does it mean? Why is it going away? The answer is you are creating why is it going away? That is how it works. I told you initially the way immunotherapy works is first thing it does is decreases the local anaphylaxis. The reason it is going away is not because patient is getting used to it. The immunotherapy is working. It is already reducing the local anaphylaxis. It is already reducing the release of histamine as well as other mediators from those buccal mucosa mast cells. So the immunotherapy is working. So that is a direct evidence of activity, of sublingual activity within the first week or two. So that is the signal it is working. Now, physician and office staff need to be aware. And written plans and consent are very, very essential. I'm not still sure whether it's still approved by the Drug Council of India. I think it's a high time that we need to do an Indian study. And also, we need to be aware of some of the dosages that you have to be aware of. So, timing is crucial. Important thing, test early, treat early, modify the disease, and reverse the march. And now, this may be a very, very optimistic slide. We can tell our patients and child for the first time, yes, I think I can halt the disease, or at least I can slow down, I can reverse it, I can probably modify it, I can probably help to, I won't say the word stop, I would say slow down the progression of child's allergies and asthma. So this is an important change in the pediatric allergy management, especially sublingual immunotherapy. And some of the things that lies beyond is, if in case you're a terribly sensitive patient, you can mix omalizumab with the subcutaneous, you can mix with these things, and that will make it safer and much more effective. Adjuvants can be used to slow down the release of antigens. Peptides are safe and effective. There's one therapy called intra-lymphatic immunotherapy, which has got showing some promise, where that lymph nodes are where everything is happening, and you inject it right there, the antigen, and that seems to make a pretty much of a significant impact. 6 injections of intralymphatic seems to last for 2 years of relief. So that is still in the research stage. The reason why there is not a whole lot of support is it is not financially that viable to the pharma industry. So hopefully it might change later on. So this is the only therapeutic modality that I can think of that can change the course of the disease. Significant advances are being made, and novel methods are also in the pipeline. And thank you for your time.
Thank you so much, Dr. Vedantam. I think in a very nutshell, you have summarized this as a huge topic of allergen immunotherapy. This allergen immunotherapy, it needs a time to understand the mechanisms, and years of practice to master it. It is one of the most advanced form of therapy available for the allergy diseases. But yes, it has its own protocols and patient selection, allergen selection, composition, the quality of the allergens, and how it is given. All these factors needed to be taken into account before you embark on this practice. And definitely it needs a proper special training for all those who intend to practice allergy immunotherapy. Thank you so much. So since we have overshooted by say half an hour, so it leaves a beautiful room for Q&A, but at least I'll take one or two questions. So one is from, where is that? So one is by Dr. Taha Qureshi from Srinagar. So this question is for Dr. Nagendra Prasad, like, can we outgrow drug allergy? So that is what he has asked. He has a case also, but this question I'll take. The consent of time. Dr. Nagendra Prasad, please. Can some drug allergies outgrow? By Dr. Taha.
Can you repeat?
Yeah, Dr. Taha is asking that can some drug allergies, we can outgrow some drug allergies? That is what he's asking.
Present condition, understanding of the drug allergy is to stop the drug reaction and stopping the drug, not outgrowing the drug allergy. The mechanism is still yet to be understood, and it is only the drug which is sensitized can be desensitized and it can be administered, which is done in the past. But with the present condition, there are so many other alternative drugs are available. So just stop the sensitive drug and continue the other treatment rather than going for a desensitization, which is very, very cumbersome and very serious conditions can be faced. So we can't outgrow the drug allergy. Stop the drug, that will give you a total safety from the drugs.
Okay, thank you. So that was very precisely, specifically answered this question. I think, Taha, you got your answer. So next is a question by Dr. Singh, and this is for Dr. Vedantan. Which allergy test is good to diagnose multiple allergens? This is one of the basic questions that is asked. So Dr. Vedantan, please.
Okay. Which test is good for diagnosing multiple allergies? You know, it's very, very common for us in US to see people with polysensitization. Okay. Not that common in India. The history comes into role. So you have to take a good history and figure out which particular antigen is clinically significant. And clinical significance of the sensitization is crucial. And that is what will be learned after years and years of allergy practice. In not one lecture like this, or not even practicing for 2 years, you won't get it. So as you practice more and more, see more and more patients, try to correlate more and more, it is an art that you will learn over a period of time. So polysensitization will actually be a challenge, and taking good history, correlating with the sensitivity and trying to figure out which is relevant, which is not relevant, is what an allergist has to learn over a period of time. So there is nothing like a single test, doing some test and say, oh yeah, you're allergic to 10 things. What I would say, you're sensitized to 10 things. But are you allergic to 10 things? You may be allergic to 2 things. So for me to find out what are those 2 things, I had to spend time. For me to say you are sensitized to 10 things, I don't have to spend any time. And that's what the skin test is showing, or the immunochem showing. So our job is to do the second history, or what we call as a summary conference, where we try to correlate these 2 things. And that is what the job of an allergist is.
Okay. Thank you. Thank you, Dr. Vedantan. So one last question I would like to ask Dr. Krishna Mohan. So since we know that in Indian cities, there is actually we have this is means now what we're getting is very poor air quality indices in the Indian cities mostly, and for this wrong reason, and cities like Delhi and all they come to the use. So, what do you think regarding this program of like the plantation of more trees is in the Indian cities, which has a very poor air quality, which with very high vehicular traffic load with high DEPs is in the atmosphere? Is the planting of more trees will cause the increase in the more allergenic pollens in the environment, or like it is always a good idea to go in this way? So what is your take on this?
I think anyway, planting trees is really good because. But the only thing is that whenever we are planning to plant trees, we should we should do a proper aerobiological study, and we should decide that we will plant only less allergenic trees, which are not producing much allergy like that. And so we already have a data with us, the allergens which are causing more symptoms, especially in the trees. So we should avoid those allergenic trees and then plant the less allergenic trees. That is what I feel. Vedantan sir will be able to add more.
Yes, Vedantan, would you like to say anything on this? Well, I'm able to hear him. Anyway, I think. Yeah, Dr. Vedantan, would you like to say anything?
Sir, I think this
I think
net connection is poor.
Net connection.
Did you call my name? I don't know. I didn't hear.
Yes, Dr. Vedantan. Yes, Dr. Krishna Mohan has said that planting of more trees in cities would be a good idea. So only the food for thought is that the cities with very poor air quality indices, like shall we go on planting trees and producing more allergenic pollens in the environment, or first of all we improve the air quality and then plant trees or something like that? This is only a debatable question which I had asked. So what is your opinion on this? So I just wanted to, and I would like to have an idea from Dr. Nagendra Prasad also before we culminate this entire. Yes, Dr. Vedantan. I think
this connection is having some problem.
Yes, Dr. Vedantan, can you hear us?
Yeah, I can hear you. One comment on trees, all trees will help. All trees will help, even allergy. But one tree, I think, I don't know, remember the exact number, it provides enough oxygen requirement for a day for at least 20 people, I think. And sugarcane has one of the best oxygen producing capacity. Sugarcane has one of the best. And also, another thing it does, it is extremely good for this global warming because it actually cools down, it holds the moisture and controls the temperature. So all these, there are not just only oxygen, but the temperature control, moisture control, overall climate control is a property of these trees. So it is a fantastic thing to add more trees as possible. And the more trees you have, more greenery you have, better off we are. Yeah. Better off. There is no doubt. Absolutely no doubt.
No, the question is Vedantan. He said that if you identify the allergen producing trees, if you remove it and if you plant the non-allergenic plants, that may be helpful for reducing the incidence of allergies. What is your comment?
Depends upon how close you are. Is it near your window? Is the tree is right by the side of your house? Yes, it can. But trees, if you look at tree pollens, these are airborne. They produce in billions. It definitely can influence your symptoms nearby, but even say like you don't have the tree, it is way over there, it will still cause problem for you, because these are airborne pollens which are in huge amounts coming in the air. They enter your house, they enter your room, they enter everywhere. So I don't think it is a major issue that we need to worry about. Oh, I cut off the plant and I will be okay. It is not true. Because that tree could be 1 furlong, half a mile from you and still bother you. It will travel, these pollens will travel miles because it is wind pollinated. So it is sort of redundant to say, yes, I have removed the tree and I am going to get better. These allergic trees will be removed and allergies will get better. I don't think that will happen.
You're right. The pollens can travel from 5 kilometers to 25, 30 kilometers also.
Yes.
So therefore, so elimination of the plants in front of your house or nearby may not be helpful in the long run.
Yes.
And secondly, suppose if you eliminate, just a proposal, just I'm telling you, just for a discussion, suppose if you remove all the allergen producing plants and if you plant only those other airborne pollens which is produced in the trees, even that may also become a sensitive in the human body in the later days to come, which may not be a sensitive right now.
Yes, you are right. New. If your immune system is prone to react, and
yes,
it reacts against certain types of proteins, and these are organic substances. They have proteins in them, and that can definitely you can have newer allergies come on, and that has been shown by studies done by Dr. Agashe, Dr. Mahesh. New allergens, they call it, new allergens. New allergies prop up, which never was there before. People are reacting to different things before. And we see this in the United States, where they say, for example, Phoenix, Arizona, where there are no much trees. So they went ahead and put all these different plants thinking everything will be okay. This is the best place. But lot of people develop allergy to it. Okay. So your immune system will react to proteins and these antigens. So these are all antigenic. Some are more, some are less. Some are known, some are not known. And some will produce a little bit, some will produce a lot. So there is a lot of variations there. So it is difficult for us to totally control with I would say it is too simplistic a solution to say, I am planting non-allergic trees, so it's all good for us. We can't say that.
Yeah, I think the point is clear. So only thing which we need to know is that while we are going for a plantation drive in a city, we need to choose the trees which are going to be planted by the horticulture department or the municipality body. So since it's important, going to have an impact on the allergenicity of that area. And why I raised this question? Because there was a tree called Alstonia spalaris, the state tree of West Bengal, which shows sensitization to the tune of around 5 to 10% in the rural areas. But this tree was chosen and was planted all along besides the roads in the Calcutta. And unfortunately, that has led on to over the period of few years, where we know the air quality in Kolkata is quite poor. It has increased the sensitization rate to the 22 to 25%. And now we have got people suffering from this Alstonia spalaris induced asthma rhinitis, especially in the early autumns. So the municipality body then took a note, and now they've stopped planting the Alstonia spalaris and they've replaced it with other trees which are not that harmful. So these are some of the contentious issues. Anyway, I think the debate will go on, but it was really a very fantastic deliberations by all the faculties. I thank them all. And I really thank Dr. Rajadhar, Dr. DJ Christopher, and Dr. Rajesh Swanakar, who along with myself, we had conceptualized this webinar series, this 4 series of the webinars on allergy and the immunotherapy. And I really thank Indian Chess Society for allowing this platform to be hosted, and the Sanofi for actually bring this entire thing to see the light of the day. And I really thank all the participants who were there. And it was really it's well thought and conceptualized, I think, in the webinar we had conducted with all the speakers who were there in all the four webinars. They have really done a great job in like bringing this important conscious topic in front of everyone. So thank you very much. And once again, I thank all the faculties who are present today, and have a very pleasant evening and good night.
Okay, good night. Namaste.
Yes.
I thank the Bansal Sanyal for giving me sharing the slides and making the smooth glowing. Thank you very much. Thank you,
Thank you,
Dr.
sir.
Saibal. Thank you.